I'd like to start by thanking the organizers for inviting me to talk on a topic that was given to me. I'm not going to talk about hormones. My background is I'm a clinical person. I'm a clinical endocrinologist, but a clinician scientist as well. This really sort of started through discussions I've been having with the Libyan Embassy last year. I've had students who have come to me to do a PhD, where they've got a basic science background, not a problem. The problem arose when I had clinical people from Libya who wanted to do an MD or PhD. That's when I saw disparity. The disparity was there were UK graduates who were doing MD, PhDs, who were clinicians, who were doing clinics, but these individuals who were coming from Libya to do a higher degree were not. And I think your conscience would tell you that is only going to de-skill these individuals, and it's a responsibility of any medical trained person to ensure no one gets de-skilled, more importantly, upskill them so that they can take it back home and apply it to their population. So that was a discussion, and we've been having discussions this morning, this afternoon, of how to take this forward. Where Warwick is that, can everyone see? Because that's shining too much. Is that okay? Yep, okay. It's got a castle, very old castle. It sits right in the middle of the country, near Birmingham. Oxford's further down. And it's a historic town, Warwick. There we go. Let's see. Okay. Just to quickly go through, we heard about Kiel. I thought I'd better do this, otherwise my Vice-Chancellor's going to kill me. These facts don't really sort of interest me. But in the 2003 poll, this is showing you how many students were there, what sort of departments are here, and really social sciences. We heard earlier the importance of it. 1/3 of the university's focus is on social sciences. It's a large campus. In terms of its ranking, it does very well. It's in the top 10, and it really sort of #1 target for graduate employers. And I think this really sums it up. It's barely 40 years old in 2006. The interesting thing is it'll be 50 next year, so will I. So there's a link between the two. I'm not going to talk about all the things what Warwick does, because I don't really pay much attention to that. I just focus on what I need to do. Is Matthew here? Matthew, can you get up, please? From our international office. Can you stand up again? 1 minute. That's the person to talk to if you want to talk about any other topic. So that's it. Thank you, Matthew. This is what it looked like in 1960, the university, and that's what the campus looks now. And there's a plan for a 3rd expansion as well, and there's more roadworks going on. So I was asked to talk about medical studies and training. I really don't know what the training program is in Libya. There was a student previously, but then the conflict broke out, so I couldn't go to Tripoli to see it. But hopefully I will. And I think whichever level you look at it, depends on university to university. You have your undergraduate or graduate level. And the undergraduate usually can be 5 years or 6 years course. You then have a postgraduate education program. So for doctors who are newly qualified, they go through supervision, and certainly in the UK, foundation year 1, then 2, then core training, and they could run through training, etc. And I think the problem, what your suggestion is a good one. I think the system will not allow graduates from Libya to get into the system, because even the UK-based ones finding it difficult to get into that system. And then you run into the problem of what to do. The CME you touched on, I think this is extremely important, which actually touches on what I was worried about, the doctors coming from Libya. And I think this, you can do it through many ways, lectures, ground rounds, conferences. But I think one has to remember, the title is Medical Studies and Training. That doesn't stop at students. It stops at consultants like myself as well, where I think mandatory training is extremely important, where for revalidation, you need to be up to skill, because at the end of the day, you're going to make decisions and you're going to be teaching. So this doesn't just sort of stop at the middle grade doctors. And I think the system is very, very tricky now. I've got a professor, and given my clinical director's duty, I've refused his revalidation. Hasn't gone down well, but I'm a responsible officer to ensure the quality and safety of the patient, so I've told him to go and do some more courses. And that's the GMC rule. Online learning is also extremely important, and I think we heard about this earlier, and I think people are doing this more and more, and a lot of people keep up to date through online learning. So I'm just going to focus on the school itself, the medical school. It's a young school, so I did my PhD in Warwick before the school was established, so I've seen it actually being built, develop, and all the different deans come and go. And it was in the 2008 in the top 10 in terms of the research assessment exercise. We'll see what it scores in the ref, fingers crossed. Sciences research is very good, but the themes in the medical schools have changed in terms of the research, and this usually occurs either through pressure from the Vice-Chancellor or the Dean or research councils, and also where research heads in terms of the UK research as well. So in terms of education, I'm going to give you a slight background of what the Warwick model is. It's accepts graduate students only. It's a 4-year course. There's 54 international students, 180 roughly per year. And the thing about Warwick is it's very well known for its masters and CPD programs. So the diabetes program is very internationally followed, and there's a list of other sort of programs that are run for education. So medical education, like I said, is not just for medical students, it keeps them going. It's a constant learning process. And I always believe you're never too old to learn. You'll learn something right to the last day on your deathbed. So in terms of research degrees, we've talked about it, these are different ones that run through the medical school, but the medical school also works very closely with life sciences, systems biology, engineering, digital health. So it's really sort of going to that way. So I think degrees are more and more encouraged in multidisciplinary approaches now. So going on to the divisions that are within the medical school in terms of providing training, you've got biomedical cell biology, health sciences is a big area, mental health and well-being. And I think this is important because we've heard earlier that in Libya, a lot of people, young people, are exposed to atrocities of war, families being lost. That's at the young age, but the other spectrum is also this aging population in the UK. And the number of people who are depressed, can't live alone, and it's a huge problem. I sit in the last division, which is translation and systems medicine, and those are some of the areas which the school focuses on, but there are more as well. But you always have to remember you can't do everything, so you have to keep it sort of focused. Now, one of the themes is metabolism. This is something everyone must have seen, but it's also happening around the world. This is the giraffe we heard about, lots of saliva. So it's a global issue. So it's, I think, the same problems in Libya. It's happening everywhere in the world. Obesity. So one of the themes of the is around obesity research, metabolics research, and there are now modules around education on that as well. So one important thing about doing anything on translation and systems medicine or any translation work is you do need a very strong partner, but the right environment. And that's one of the things when students come to approach me and say, would they want to do research, I actually point them to the person who can actually give it rather than me pretending I can do it. Because you do no service to the student and you do no service to yourself. So both parties end up failing. And I think we're fortunate we've got a number of people who can take on these students. And this is the partner. Like I told you, I'm with a clinical background, and for my research, so I can work from cells, animals, to humans and back. That's what my research is. We're very translational. But I need the patients. I need the subjects. And I think that's where you need a very, very close collaboration with the NHS partner. I was saying to Matthew, my dean didn't agree me becoming a clinical director 3 years ago. And I sort of said, well, how are you going to change the mindset of NHS consultants who just park their car 8 o'clock in the morning, do their work, see their patients, and drive back home? A few of them do research, don't get me wrong. So you have to build within, and within, through research, you develop training, you develop innovation, you change in your practice, and you're doing what really needs to be done. And if you look at the American system, which is around academic health systems, or now in the UK, health sciences research networks which are set up, it's linking the clinical side, linking the research, linking industry, linking technology, and so forth. So you do need, through all of this, it's not all about universities. You need the patients, so you need to engage people working together. I think that's extremely important for training for medical studies. So in terms of the hospital, that's what the hospital sees, around about 600,000 people. There's about 6,000 staff, 6,000, 7,000 now deliveries, because one of the hospitals is linked into us. So huge amount of experience for students, for research, but also training opportunities here. Within the NHS, what we've done now is, in our NHS partner, is trying to sort of improve education for the trained doctor as well. So, for example, robotic surgery is there, so it's state-of-the-art, so you can do robotic surgery, anatomy skills. It's got a non-antibody incompatible kidney transplant program, which actually Harvard ring us and ask us how to do it, because it was Rob Higgins who actually set it up. And these are just some of the examples that one can do. So research, whatever you do in research, whether it's at a cell level, or it's on digital health. I saw a poster at the back as well. You always need your patient cohort, but whatever research you do has to have some form of impact. And I think that's one of the things that the HEFC or the REF has actually sort of said, and it's starting to make you focus. It's not just about getting a result and the Western blot works and say, well, here's my result and I'm going to get a paper. What impact is that going to have? And what difference is that going to make? So I kept it short purposely. I thought we could have more questions, because I know the speaker before would have covered a lot of points. There's not much you can talk on medical studies and training, but I would highlight the issue, really why this all came about was I had living doctors and they were getting de-skilled. So one of the things that we worked on is that they got their PLAB exam, they got GMC registered. The program that we now have with the NHS partner is they have a clinical supervisor, they have an academic supervisor, they will do 2 clinics a week, and they will do the same as what's expected from clinical academics who undertake higher degree. So that there is that sort of fairness and responsibility of ensuring that they get the education and training and they actually leave better doctors, and so that also in the future they have their clinical mentor and academic mentor if they're back home to run ideas or develop collaborations. So in terms of this is one of the things that is in the trust. We invested at £2 million. There's 4 of these in the world, 2 in the UK, 1 in Cambridge, 1 with us. It measures basically your metabolic rate. So it's basically like calorimetry, but with a whole animal, the animal being the human being. This person's too fit to be, but this is my colleague Tom Barber who put this lady in and took a photograph. And these are sort of the slight sort of areas of interest that we do, which are metabolism, aging, brain, all areas which impact society. So this is a very small part of metabolism. And this just to highlight my idea about training. You can train in a laboratory, you can learn how to do it on animals, you then have to apply it, and what you do is, this is a scan basically just showing where the orange bits is, because you probably won't come up with my pointer. Here we go. These areas here and that, which lights up. This is an FDG PET scan, which sort of lights up in tissues which are very metabolically active, high mitochondria. and this is usually to detect cancer. So if there was a lung cancer, it would have shown up. So this is the method which was applied, and this is looking at, say, brown fat. So then what we looked at was, from the animal model, so this guy here moved from Oxford and brought this guy up, and they sort of asked the question, we got this, how do we sort of look at it? I said, well, first thing you do, take a mouse, put it cold, put it in a scanner, see if it shows up. It showed up, I said, there's your proof of concept. Then you do it the same with the human, you get your PET scan, you get your MRI, and I think this was looking at a non-toxic way of looking at it. And what this shows is, this is basically what we call ideal MRI, non-invasive, and it picks it up. So it's a new technology, same scanners, but using application of how we can detect brown fat in humans. So my point is, you do not waste a clinician. You apply training to them, you get them sort of thinking, and you put them in the system, as was said by the last speaker. You do not isolate them on the side. So my sort of final slide, and Chairman, I think I've kept within 10 minutes, is the Strong Medical Education Hub and Health Education Hub at the university offers very exciting opportunities for training and medical studies. We have huge number of students from abroad. It's an extremely good campus. I would urge you all to go and talk to Matthew. He feels a bit lonely, not having spoken to anyone. But from my point of view, and from clinicians who are coming to do research with me, I have got buy-in from the NHS partner, and it helps being a clinical director. You can persuade the chief medical officer that this is important for not just research, but also training education, so that the doctors who do come to do research with us play an active role in research development, innovation, but also their own professional development. Thank you.